We looked at the chambers and some of the big vessels of the heart. Now let's start looking at the valves themselves. Valves are there to make sure blood flows in only one direction. If blood is flowing in two different directions inside of your heart, in other words, if it's flowing one way through a valve and another way through a valve, things have gone seriously wrong. We need to make sure the blood goes in one single direction through the heart. You have what are called atrioventricular valves, AV valves, we'll always call them, we'll abbreviate them, that's fine, you can too. Those are in between the atria and the ventricles, all right? So therefore there have to be two of them. There's one between the left atrium and the left ventricle, and one between the right atrium and the right ventricle. These are open when the heart is at rest. So these valves are normally open. When your heart is at rest, not actually pumping blood, not actually beating, these valves are open. They're closed when the ventricles contract. So they're normally open because you want blood returning from either the body or the lungs to be able to trickle into the ventricles. Because remember, the ventricles is where we pump the blood out. So these valves are open most of the time. Then when the ventricles contract, that's what forces the valve shut. It's the force of the contraction of the blood being pumped that actually the blood, the fluid itself, forces the valve shut. They prevent backflow into the atria when the ventricles contract. So once again, you do not want blood going back up into the atria. Atria is where the blood came from. When it came back from the body, it came into the atria. We want it to trickle down into the ventricle, and then when the ventricle contracts, we want it to go out through either the aorta or through the pulmonary trunk. We do not want it going back up into the atria. That's called regurgitation. And you can hear that through a stethoscope. That's what makes the sound that they call the heart murmur. Heart murmur is usually a valve problem. It means that blood is flowing backwards in the heart. It's going the wrong way through the valve. So on the right side is the tricuspid valve, and it's called that because cusp, like a flap, it has three flaps. So the right atrioventricular valve has a nickname. It's called the tricuspid valve. The left atrioventricular valve is called the mitral or bicuspid. It has only two flaps. It's called the mitral because two flaps looks kind of like the hat that bishops wear, like in the Catholic Church. Like the bishop on a chessboard has a little slit, makes it look like it has a hat with two flaps. So that's how it got the name mitral, either mitral or bicuspid. So the right AV valve we also call tricuspid. The left AV valve we also call mitral or bicuspid. And you have to know all those names. All use them interchangeably, so you have to know what I'm talking about. The chordae tendineae anchor the AV valve cusps to the papillary muscles. So chordae tendineae, literally the tendinous cords, they connect the valve to the papillary muscle. All right, so look on the bottom illustration there, and on the top as well. You can see the papillary muscles pulling on the chordae tendineae. So the chordae tendineae, those are your heartstrings. Have you ever had someone pull on your heartstrings? Well, that's what they were pulling on. So the valve itself, the cusps of the valve, are attached by the chordae tendineae to the papillary muscle. All right? Now, here's something that everybody seems to get mixed up, so don't do it, all right? It's normal to get it mixed up at first. You just have to get it straight so you don't get it mixed up again. The papillary muscles do not pull the AV valves open. Remember, the AV valves are normally open. The AV valves close when the ventricle contracts, and that forces blood. Think of the ventricle as being like a toilet paper tube. All right, if you have fluid in a toilet paper tube and you squeeze the middle of the toilet paper tube, fluid's going to come out both ends, isn't it? So when the ventricles contract, they're trying to pump blood in two directions. One direction would be back up through the valve, and the other would be out into either the aorta or the pulmonary trunk. So we want the blood to go into the aorta and the pulmonary trunk. We do not want it to regurgitate back into the atria. The valve would actually go back the wrong way. That's called prolapsing. With the AV valve, if it prolapses, then blood would go back in, and that's very bad. That normally means you're going to have to get surgery on the valve to fix it. But under normal circumstances, what will happen is, as you squeeze that toilet paper tube, some of the blood will try to force its way back into the atrium. That will cause the valve, the AV valve, to close. And then the purpose of the papillary muscles is to pull on those chordae tendineae so that the valves don't prolapse. In other words, it's holding them shut. It's kind of like a powerful wind is trying to blow the door open, and you're holding the door shut. That's what the papillary muscles do. They hold the valve shut as the blood that's being pumped by the ventricle forces the valve shut. They hold it shut and prevent it from prolapsing, and therefore prevent blood from regurgitating into the atria. Okay? Hopefully you got a clear picture then in your head. Don't get that mixed up. So continue with heart valves. We have what are called the semilunar valves. Semilunar valves are normally closed when the heart is at rest. So they're typically closed, unlike the AV valves, which are typically open. They're opened by the force of blood during ventricular contraction. So look in the bottom diagram. When the ventricle contracts, let's look at the right ventricle, all right? See, it's full of blood. That when the ventricle contracts, that blood is trying to get forced back up into the right atrium where the vena cava are, all right? And the papillary muscles are holding, or they're pulling on those chordae tendineae to hold that AV valve shut. On the other hand, then, from the right ventricle, we've got blood going up into the pulmonary trunk. So those semilunar valves were normally shut. It's the force of the blood that now forces them open, all right? And that's the way it's supposed to work. The force of the blood being pumped by the ventricle pushes those semilunar valves open, and that allows blood to flow into the aorta and into the pulmonary trunk. They prevent backflow. So in this case, once again, you don't want blood that's being pumped through the aorta and through the pulmonary trunk. You want it to go to the body or to the lungs. You do not want it to leak back into the ventricle. So now what happens is it's basically, you see how the ventricle forms an arch? The aorta forms an arch. So when blood gets pumped through the aorta, some of it will make it over the arch and go out to the body, but some of it will make it, all the way up to the top. Think of like going up into the top of the roller coaster. Thank goodness that chain pulls you over the top. If it weren't for the chain, you would slip back down. Some of it will slip back down, and that blood slipping back down will shut the semilunar valves. So they are closed by the backflow of blood, and that's so that the blood doesn't backflow into the ventricles. The valve will stop the blood from backflowing into the ventricles. So there's the aortic semilunar valve that prevents backflow from the aorta into the left ventricle, and there's the pulmonary semilunar valve that prevents backflow of blood through the pulmonary trunk into the right ventricle. So once again, make sure to keep this straight. The semilunar valves are normally closed. They're opened by the force of contraction, ventricular contraction, and they prevent the backflow of blood into the ventricles, all right? Go through that a few times. Go back through and make sure you're really seeing how the valves work. Once again, their main job is to ensure that blood flows only one way through the heart. We do not want blood backing up into the heart, ever, all right? So pumps and destinations, the heart is two side-by-side pumps. Really, the left side of the heart is pumping blood to the body. The right side of the heart is pumping blood to the lungs. So it's really two side-by-side pumps, pumping blood to two different places. Right side, we say, is the pulmonary circuit. That's to the lungs. Pulmonary means lungs. Vessels that carry blood to and from the lungs. Left side is the systemic circuit. Systemic means the rest of your body. We have vessels that carry blood to and from the body tissues, all right? So two pumps. The heart is really two independent pumps, but they function simultaneously. So note that the blood pumped to the lungs by the right side of the heart is the same blood that returns from the lungs to the left side of the heart. Therefore, what that means is, and sometimes people get mixed up by this, don't be one of the people who gets mixed up. Both sides of the heart have to pump exactly the same amount of blood. I can see why people get mixed up, because you think, well, the lungs, those are just two little small spaces, but the rest of your body, that's a lot bigger, so you must have to pump more to your body. No, it can't work that way, because remember, the blood that's getting pumped to your lungs comes back, right, into the left atrium, then into the left ventricle, and then that same blood gets pumped into the body. If one side of the heart were pumping more blood than the other, that means blood would be backing up on one side of the heart, and that wouldn't work. you would end up with all the chambers overflowing back out into the vessels. So both sides of the heart pump exactly the same amount. The blood that comes back from the body gets pumped to the lungs. Then it comes back from the lungs, and then it gets pumped to the body. And then it comes back from the body, and it gets pumped to the lungs, and so on. It's the same blood. The same blood that comes back is the blood that gets pumped on the next beat. Both sides pump exactly the same amount of blood. So let's look at the pathway of blood through the heart. I want you to know this. The nursing school in particular says, don't send us anybody who can't tell us exactly how blood travels through the heart. So here you go. Blood starts in the right atrium. All right, follow through on the diagram. It goes through the tricuspid valve, or the right AV valve, goes into the right ventricle. From there, it goes through the pulmonary semilunar valve, into the pulmonary trunk, into the pulmonary arteries, the left and right pulmonary arteries. Remember, it's pumping blood to both lungs, so pulmonary arteries. Then in the lungs, it goes into the pulmonary capillaries, and that's where we put oxygen into the blood and take CO2 out. Then it comes back to the heart through the pulmonary veins, left and right pulmonary veins coming from both lungs. It goes into the left atrium now, so the left and right pulmonary veins lead into the left atrium. From there, it goes through the bicuspid valve, or the mitral valve, or the left AV valve. From there, it goes into the left ventricle, then up through the aortic semilunar valve, then through the aorta, then into the systemic and coronary circulations. So systemic arteries will carry it out to your body. Coronary arteries will carry it to your heart. Your heart is an organ. It needs blood. It needs oxygen and glucose, so it has to pump blood to itself. So there's really three circulations here altogether. There's the pulmonary circulation, the systemic circulation, and the coronary circulation. Blood has to get sent to the lungs, it has to get sent to the body, and it has to get sent to the heart itself. Mitral valve is found where? Between the right atrium and the right ventricle, at the entrance to the pulmonary trunk, between the left atrium and the left ventricle, at the entrance to the aorta, or at the opening of the coronary sinus. Yeah, between the left atrium and the left ventricle. Okay? Now, looking again at the pathway of blood through the heart, we said before that equal volumes of blood are pumped to both the pulmonary and systemic circuits. All right? Remember, both sides of the heart pump exactly the same amount. They have to, otherwise it wouldn't work. You would have pipes overflowing. Both sides pump exactly the same amount of blood. But think about it. The left side of your heart has to pump blood to your body. It has to pump blood up to your brain against gravity, going uphill against gravity. But the right side of the heart is only pumping blood to your lungs. How far is it from your heart to your lungs? It's a matter of just a few centimeters. All right? So therefore, even though both sides pump the same amount, if we look at the thickness of the myocardium, it's very different. All right? The pulmonary circuit is a short, low-pressure circulation, whereas the systemic circuit encounters a lot of resistance, and the anatomy of the ventricles reflects those differences. Left ventricle has much thicker walls because it's pumping uphill against gravity. It's got to pump all the way out, all your arms, your legs, all of your torso, whereas that right ventricle only pumps to the lungs. So a huge difference in the thickness of the myocardium, even though they pump exactly the same amount of blood. So we said you have a pulmonary circulation, you have a systemic circulation, you also have a coronary circulation. The heart has to receive blood. It has to pump blood to itself. Functional blood supply to the heart muscle itself. That's what we mean by the coronary circulation. So arterial supply varies considerably and contains many anastomoses, which are junctions among the branches. From one person to another, there are lots of little tiny differences in the exact layout of the coronary circulation. Notice there are lots of junctions, so look on the left side. See all those are the coronary arteries pumping blood to the heart itself. See how they have lots of branches? Those are the anastomoses. Why do you suppose they have lots of branches? So notice, like the right ventricle there, it's getting blood from several different sources. It's got arteries coming to it from several different directions. Why would that be the case? Well, that provides alternate routes, and I jumped past that slide, but we can still look at it on this one. Jump past that last comment on that slide. What's going on is, what if you had a blockage in a coronary artery? If there were only one way for blood to get to a certain part of the heart, then if that artery got blocked, that part of the heart would not get blood. So in fact, what happens is we have many anastomoses. Therefore, any particular part of the heart muscle gets arteries coming from several different directions. So that in case one of the arteries gets blocked, there are detours. Blood can take detours. It's kind of like, you live in a neighborhood. If they're doing, road construction on one of the streets in your neighborhood, it's not like you're trapped in your neighborhood. There's usually, you can take a different way to get out. You may have to make different turns and may be inconvenient, but you can still get out of your neighborhood. Same thing with the heart. All the different coronary arteries make sure that even if one gets clogged up, there are other ways to get blood to all the parts of the heart. So we have arteries. We have the right and left coronary arteries. Those are in the atrioventricular grooves, atrioventricular sulci, all right? Then we have the marginal, the circumflex, the left anterior interventricular, and the posterior interventricular. So the left anterior interventricular is also known as the LAD, the left anterior descending artery. That's the one on the left-hand side. You see that huge artery coming down the front of the heart. That artery is sometimes called the widowmaker, because that's where coronary blockages sometimes occur. And that pumps an enormous amount of blood that gets to the ventricle. And even in spite of all the anastomoses, if you get a blockage in that left anterior descending artery, the LAD, the left anterior interventricular, that will lead to usually a massive heart attack, a myocardial infarction. There's another big one that you can't see in that diagram going down the backside. That's the posterior interventricular or posterior descending artery. Those are the two main causes of heart attacks, blockages in those arteries. Now, the left coronary artery branches almost immediately after coming off of the aorta. It branches into two main branches. One is the LAD, goes down the front. The other is called the circumflex branch, and that goes around the heart through the atrioventricular groove. On the right side, once again, the right coronary artery branches. It branches into what are called marginal branches. Those are all the little tiny branches. And then on the back side, there is the large PDA, posterior descending artery or posterior interventricular. Okay, so take a little time and run through those and make sure you understand the different arteries on the heart. Veins, so after the heart pumps blood to itself, the blood has to comes back through veins. So the small cardiac, the anterior cardiac, the great cardiac veins, those are all returning blood back to the heart. And the coronary sinus is on the posterior side of the heart. It's basically where all the blood coming back sort of pools into a big giant vein, and that leads into the right atrium. So the coronary sinus sort of collects all the blood coming back, and then it goes into the right atrium. Let's talk about some homeostatic imbalances, which we've kind of been talking about. Let's formalize some of these. What happens when things go wrong in the circulation of the heart? So, angina pectoris, some people say angina, I don't care either way. This is thoracic pain caused by a transient deficiency in blood delivery to the myocardium. So see there in the upper illustration, well, and in the lower, you've got arteries that get atherosclerotic plaques. This is where basically junk collects. It's kind of like in old pipes, gunk collects on the inside of old pipes. Same thing happens with your arteries. Gunk collects, and basically it can get narrower. It can narrow the opening, so it gets harder and harder for blood to get through. So on the bottom you see there a plaque in a coronary artery. Well, what will happen is, as long as you're just sitting down, if you're at rest, normally the heart can get enough blood to itself. But like if you walk up a flight of stairs, now you're using a lot more muscles. you have to pump more blood. You have to pump more blood to your heart because it's working harder. And if it's already narrow and clogged up, it can now be difficult for the heart to pump enough blood to itself. And that's when you start experiencing the pain that's called angina pectoris. It feels like pain deep to the sternum, right behind your sternum. People say it feels like an elephant sitting on their chest. You feel this pain and this constriction, and it's all because you're not pumping enough blood. All right, cells get weakened as a result of that. And then a myocardial infarction, this is all informally known as a heart attack. This is when, after often happens, angina pectoris can be a precursor. As the plaque grows larger, it's harder and harder to pump the blood. Finally, the plaque just completely closes off, and you get a blockage. When you get a blockage, that means you can't pump blood to your heart, and obviously that's very serious, a prolonged coronary blockage. What will happen now is, remember, all the cells of your body need oxygen and glucose, and if they don't get it, they die. So in a myocardial infarction, part of your heart is actually dying, okay? Now, the problem with that is, first of all, you might die if your heart dies, of course. Even if you recover from a heart attack, though, you now have got dead tissue, and it doesn't grow back. It grows back with non-contractile heart scar tissue. What that means is after a heart attack, your heart is now weaker. You now, instead of having all your heart being functional myocardium, some of your heart now is just scar tissue, non-functional scar tissue. So with each increasing heart attack, your heart gets weaker and weaker. Dick Cheney, former president of the United States, had 5 heart attacks. I'm surprised the guy was still walking around. And everybody should know CPR, just in case you don't. Nice illustration. Number 1, blame someone. You did this. The victim is hurt. Use your finger to assign blame. Shame the person. Number 2, check to see if the nipples are hard. If not, rub the forehead. Kiss centrally. This is your chance. Then apply Capri Sun straw to the neck. This is important. Just do it. Don't ask why. Optional, squeeze some Capri Sun liquid into the victim's mouth. The flavor explosion may revive him. Use the hand to reharden the nipples. Don't let those puppies get soft. And then as life leaves the body, picture how great your life could have been together. And once the person is dead, feel free to enjoy any remaining Capri Sun liquid. Very important. Make sure you know your CPR. Any doctor here? I'm a doctor. What's going on? A heart attack. I'm a doctor in nihilistic philosophy. He's going to die. Aren't we all? Yeah. Okay, so let's finish up here with homeostatic imbalances, a coronary artery blockage. Let's zoom in on this and figure out what's going on. How do you fix it? Well, one way is angioplasty. Angioplasty means basically you take a balloon and you put it into the artery, and then you inflate the balloon in order to compress the plaque. Oftentimes they'll go in like through your femoral artery, and they basically snake the little wire up around. I mean, they're looking at a fluoroscope or something, so they're actually looking, and they're snaking that tube until they make it all the way up into the coronary artery that has the blockage. Then they inflate the balloon in order to try to smush that blockage down, and then often they leave behind a little plastic cage, and that's called a stent. So students get this mixed up. The procedure is not called a stent. A stent is the plastic cage you leave behind. The procedure is called angioplasty. Make sure to get that right. I expect you to know that. Angioplasty. Now, oftentimes they'll start by using angioplasty. If you've got a blockage, if you've got some angina pectoris, they'll try to use angioplasty first, because that's an outpatient procedure. Oftentimes, though, the plaque comes back. What do you do in that case? Now you got to go for a coronary artery bypass graft, CABG. They'll call that a cabbage. You'll hear on the nursing wards, they say patient in 406 is there for a cabbage. And you're thinking, what? They're making coleslaw? No, it means they had a coronary artery bypass graft. What you do in this case is you actually reroute blood. So look in the lower left diagram. You got that blockage in the LAD, in the left anterior descending artery. They'll take a little chunk of vein usually. They'll use like the saphenous vein from your leg. I guess sometimes they use veins from the arm. But you got lots of veins. You don't really need all of them, so they'll just cut a little chunk out of a vein, and then they literally sew it into the aorta and then into the left anterior descending artery. So they go around the blockage. That's why it's called a bypass. They bypass the blockage, all right? Saphenous vein used to do that. And this, of course, they don't do this one first because they actually have to, you need a rib cracker for one of these. This is going to be a 6-week recovery, thereabouts, all right? You're going to have to be hospitalized. It's going to be a long recovery because all those bones have to heal up. So this is a much more involved procedure. Normally they try to do the angioplasty first. If that's not working, then you have to do the cabbage. And here you see you can get a single bypass, a double bypass, a triple bypass, quadruple. That just means how many blockages do they have to route around, all right? David Letterman, the former late-night talk show host, he had a quintuple bypass. They bypassed 5 of his coronary arteries, and, I mean, he's still alive. He's lived for another, 20 years or whatever. Normally, this is a good procedure. It works very well. But, again, it's going to take some recovery time.